Welcome to the Deep Dive, where we cut through the noise and get straight to the essential insights. Today, we're taking a journey, a really important one, into the lower limb and the gluteal region. Think of this as a foundational deep dive, especially if you're just starting out on your medical adventure. Our goal today isn't just, listing facts. It's really about equipping you with core knowledge, some anchors to help you remember things, and yeah, some practical stuff like how to give an injection safely without hitting a major nerve. We want you to understand not just what is there, but why it all matters, so you can build a really solid base for everything that comes next clinically.
Exactly. And what's so fascinating, I think, about the lower limb is how all these different the bones, vessels, nerves, they all just integrate perfectly. It's all about providing support and, of course, locomotion, letting us move. For a first-year med student, getting these connections early is like learning the body's language. It helps you anticipate things, diagnose, and ultimately be more effective with your future patients.
Okay, so let's start right there. Basic functions. When we think lower limb, we think walking, running, right. But it must be more fundamental than that.
Oh, absolutely. You're right on track. Its main roles are basically threefold. First, and maybe most obviously, it has to support our entire body weight against gravity all day long. Second, locomotion. That's our ability to move around, walking, running, jumping. And third, it provides these really crucial points for muscles to attach. That's what allows all the powerful movements. It's really our foundation and our primary way of getting around.
You mentioned movement, and that makes me think about joints. There's always this kind of balancing act with joints, isn't there?
That's a really great point.
Yeah.
Yeah, whenever we look at joints, especially in the limbs, we're constantly comparing and contrasting their stability versus their mobility. Some joints, like the hip, they prioritize stability. It's a deep socket built for strength, for bearing weight. Others, maybe like the ankle, need more mobility, more flexibility to adapt to uneven ground. Understanding that balance is, well, it's fundamental to understanding how the limb works.
Stability versus mobility. Okay, that makes sense. So as we're thinking about function and structure, let's talk layers. We've got the skin, obviously, then what's underneath. There's the superficial fascia, right? That looser stuff with fat, nerves, vessels, lymphatics, kind of the padding.
Exactly. It's like the body's packing material in a way. Protective, insulating. But then, deep to that, you hit the deep fascia. And this is different. It's dense, it's tough, it wraps around the muscles really tightly. You could almost think of it like a natural compression stocking, but on the inside.
An internal compression stocking. I like that. So it invests the muscles, gives structure.
Precisely. It holds everything in place, creates compartments, and even provides attachment points for some muscles, which helps them work more efficiently. It's really important structurally and functionally.
Okay, so we've got these layers, this deep fascia holding things in. Speaking of holding things in, especially powerful muscles, let's pose our first challenge question for you listening. Keep this in the back of your mind as we go. Question 1. If you had to pick one muscle, the real powerhouse for climbing stairs or just getting up from a chair, which gluteal muscle would that be? We'll come back to it.
That's a good one. And thinking about that deep fascia leads us nicely into how the limb is organized.
Yeah.
It's not just one solid structure. It's cleverly divided into compartments. These aren't just, arbitrary divisions. Each compartment has its own set of muscles doing a specific job, its own nerve supply, its own blood vessels. It's like specialized zone.
Right, zones. Okay, let's map those out. Starting with the thigh. How many compartments there?
3 main ones in the thigh.
Okay.
You've got the anterior compartment. Think quadriceps. That's mostly for extending the knee, kicking.
Posterior, knee extension. Got it.
And then the posterior compartment, that's your hamstrings.
Okay.
Their main job is flexing the knee.
Posterior, knee flexion. Okay.
And finally, the medial compartment. These are the adductors, bringing your leg back towards the midline.
Medial adduction. So like an acronym, APM for the thigh.
Yeah.
Anterior, posterior, medial.
APM. Yeah, that works.
Cool. And does that pattern continue down into the leg below the knee?
It does. Very similar setup. Again, 3 key compartments in the leg. You have the anterior compartment. These muscles lift your foot and toes up. That's dorsiflexion.
Anterior, dorsiflexion, lifting the foot.
Then the posterior compartment. These are your powerful calf muscles. They put your foot down, plantar flexion. Think standing on tiptoes or pushing off when you walk.
Posterior, plantar flexion, pushing off.
And the third one in the leg is the lateral, or sometimes called the fibular compartment. This handles eversion, turning the sole of your foot outwards. Helps with balance on uneven ground.
Lateral eversion. Okay, so for the leg, maybe APL, anterior, posterior, lateral.
APL, perfect. APM for the thigh, APL for the leg. Nice anchors.
And you mentioned These compartments are formed by that deep fascia, separated by
Yeah.
tough walls, the septa. That sounds like it could cause problems if something goes wrong inside one.
Oh, absolutely. That's the critical clinical point. Because these compartments are enclosed by that tough, unyielding fascia, if you get swelling in there from trauma, bleeding, even infection, the pressure can build up really quickly. There's nowhere for the swelling to go.
Right.
And that increased pressure can squeeze the blood vessels and nerves within the compartment.
Oh, wow.
It can cut off blood supply, damage nerves. It's called compartment syndrome.
Hmm.
And it's a true surgical emergency. You have to relieve that pressure fast. So
Mhm.
understanding these zones isn't just academic, it's vital.
Definitely sounds critical. Okay, so we've got the structure, the compartments. Now, how do they all get their instructions, the marching orders? That has to be nerves.
Right, exactly. It all comes down to the nerve supply, which originates from a really complex network called the lumbosacral plexus.
Texas, like a braiding of nerves.
Precisely. Think of it like a big, intricate junction box or switchboard for the lower limb. It's formed from spinal nerve roots L1 all the way down to S4, and it's sort of divided. The upper part, the lumbar plexus, L1, L4, mostly handles the anterior structures, like the front of the thigh. It actually forms within the psoas major muscle.
Okay, lumbar plexus, L1, L4, mostly anterior.
Then lower down, you have the sacral plexus, L4, S4.
Hmm.
This one mainly takes care of the posterior stuff, the gluteal region, back of the thigh, most of the leg and foot.
Sacral plexus, L4, S4, mostly posterior.
Got it. So who are the big players coming out of this switchboard, the main nerves?
Well, for motor control, there are a few really key ones. From the lumbar plexus, you get the femoral nerve, that's L2, L4. It powers the anterior thigh muscles, your quads, for knee extension. Super important.
Femoral nerve, L2, L4, anterior thigh, knee extension.
Okay.
Also from the lumbar plexus, the obturator nerve, again L2, L4. This one goes to the medial thigh, handles hip adduction, bringing the legs together.
Obturator nerve, L2, L4, medial thigh adduction.
But the real giant, the king of the jungle, emerging mostly from the sacral plexus, is the sciatic nerve. That's L4 down to S3.
Sciatic nerve.
Ah.
Everyone's heard of sciatica. It must be huge.
It is. It's the largest nerve in the entire body. Truly the superhighway, running down the back of the leg. And what's crucial to understand is that this superhighway eventually splits into two major branches.
Okay.
First, the tibial nerve. This continues down the back of the leg, supplying the posterior thigh muscles, the hamstrings, then the posterior leg muscles, the calf muscles for plantar flexion, and also muscles in the foot.
Tibial nerve. Handles posterior thigh, posterior leg, foot. Lots of work.
A huge territory.
Mm.
Then the other branch is the common fibular nerve, sometimes called the common peroneal nerve. This one swings around laterally near the head of the fibula bone.
Near the fibular head. Sounds exposed.
It is. It's quite superficial there, making it vulnerable to injury. A direct blow, prolonged pressure, even a tight cast can damage it. And this common fibular nerve then divides again into the superficial fibular nerve, which supplies the lateral compartment of the leg, those everminor muscle,
Lateral leg.
and the deep fibular nerve,
Right.
which goes to the anterior compartment of the leg. It handles dorsiflexion, lifting the foot up, and extending the toes.
Anterior leg, dorsiflexion. So if you damage that deep fibular nerve,
You get a foot drop.
Mhm.
The inability to lift the foot. Patients often develop a characteristic high-stepping gait to avoid tripping over their toes. It's a classic sign.
Wow, okay, that sciatic nerve truly is a superhighway with critical exits and junctions. Which leads us to our second challenge question, thinking about that massive sciatic nerve. Question 2. Through which specific opening, which foramen, does it actually leave the pelvis to start its journey down the leg? Mull that over. Now, nerves are the wiring, but everything needs fuel and drainage. Let's talk plumbing, the blood supply. Arteries bringing the blood in, veins taking it out.
Right. And the major artery here is the femoral artery. It's a continuation of the external iliac artery once it passes under the inguinal ligament. Its path is incredibly important clinically. In the upper thigh, in the femoral triangle, it's relatively superficial. Easy to feel the pulse there.
Which is great for assessment.
Exactly. But it also means it's vulnerable. You mentioned stab wounds earlier. This is a common site, and bleeding can be massive.
Right.
As it goes down, it passes through the adductor canal and emerges behind the knee as the popliteal artery. Here, it's close to the femur. In aneurysms, these balloonings of the artery wall can happen. You might feel a pulsatile swelling.
Behind the knee.
Then it continues down the leg, eventually branching to supply the foot. You can feel its pulse again behind the medial malleolus, the inner ankle bone, in the tarsal tunnel.
Oh.
And importantly, near the hip, it gives off circumflex branches. These wrap around the neck of the femur and are vital for supplying blood to the femoral head, important in hip fractures.
So many palpable pulse points. Femoral triangle, popliteal fossa, posterior to medial malleolus, essential landmarks for any clinician.
Absolutely essential.
Okay, that's the in-pipe. What about the out-pipes? The venous drainage. Sounds like it might be complicated.
It is a bit more complex. You basically have two systems, deep veins and superficial veins. The deep veins often run alongside the arteries, sometimes even in pairs, sharing the same sheath. They're often called vena comitantes, meaning accompanying veins.
The accompanying veins.
Yeah, and the pulsation of the nearby artery actually helps push the venous blood along. Then you have the superficial veins, which are closer to the skin.
Okay, and who are the main players in the superficial system?
Two big ones you need to know. The great saphenous vein, also called the long saphenous, it runs up the entire medial or inner side of the leg and thigh.
Great saphenous, medial side. That sounds familiar. Isn't that used in surgery sometimes?
It is, because it's long, accessible, and usually a good size. It's often harvested for coronary artery bypass grafts, CABG surgery.
Wow, okay. And the other one?
The short saphenous vein, or small saphenous, this one runs up the back of the calf, more laterally. And crucially, these superficial veins connect to the deep veins via perforating veins. They perforate the deep fascia to allow blood to drain inwards from superficial to deep.
Okay, so blood flows from superficial to deep, and then the deep veins carry it back up. But how does it fight gravity all the way from the foot? It can't just be heart pressure alone, can it?
No, you're right, not entirely. This is where the amazing muscle pump mechanism comes in, especially in the calf.
The second heart. I think I've heard that term.
That's exactly it. When your calf muscles contract, like when you walk, they squeeze the deep veins embedded within them. This compression propels the blood upwards towards the heart, and to stop it falling back down.
Valves. There must be valves.
Bingo. All these veins, superficial, deep, and the perforators have valves. They act like one-way doors, ensuring blood flows only towards the heart and prevents backflow.
Clever design. But what happens if those valves, those one-way doors, fail?
Well, that's when you run into problems. If the valves become incompetent, leaky, blood can flow backward or reflux. This increases pressure in the superficial veins, causing them to dilate, become tortuous and twisted, and that's what we see as varicose veins.
So leaky valves lead to varicose veins. Makes sense. Are they just cosmetic?
Often they are, but they can also cause aching, swelling, skin changes, even ulcers in severe cases. Risk factors like pregnancy, obesity, prolonged standing, and just age can contribute. And thinking about venous problems, we also have to consider the deep system. A deep vein thrombosis, or DVT, is a blood clot forming in those deep veins.
A DVT. That sounds serious.
It is. It can cause pain, swelling, redness in the leg. But the biggest danger is that a piece of the clot, an embolus, can break off.
And travel.
Exactly. Travel through the bloodstream up to the heart and then get pumped into the lungs, causing a pulmonary embolism, PE. And a large PE can be fatal.
Wow. So DVT prevention, like using blood thinners in at-risk patients, is crucial.
Absolutely critical. Recognizing the signs and risks is key.
Okay. Arteries, veins, muscle pumps, valves, DVTs. One more part of the plumbing. The lymphatics.
Yes, the lymphatic system. Often overlooked, but vital. These vessels run alongside veins, collecting excess fluid from the tissues, along with proteins and other stuff, and returning it to the bloodstream. They're also crucial for immune surveillance, transporting immune cells.
And they drain to lymph nodes, right? Where are the main ones for the lower limb?
Most of the lymph from the lower limb eventually drains upwards toward the groin into the inguinal lymph nodes. There are superficial and deep groups there. The superficial inguinal nodes receive lymph from the leg, the lower abdominal wall, the gluteal region, external genitalia. They're arranged in horizontal and vertical chains. Then they drain into the deep inguinal nodes. There are also some nodes behind the knee, the popliteal nodes.
And knowing where these nodes are helps if someone has an infection or cancer spread.
Precisely. Enlarged or tender lymph nodes can indicate infection, inflammation, or malignancy in the area they drain. Palpating these nodes is a fundamental part of a physical exam.
Okay, plumbing system covered. Now let's circle back and zoom in on that region we mentioned drains there, the gluteal region, the buttock. It's clearly more than just padding for sitting.
Oh, much more. The gluteal muscles are incredibly powerful. They're essential for moving the thigh at the hip joint, particularly for extension, abduction, and rotation. Think about powerful actions. Climbing stairs, getting up from a seated position, even just stabilizing your pelvis when you walk so you don't waddle. That's largely the gluteal muscles at work.
So who are the main muscles back there? I know there's a maximus.
There is indeed. You have the superficial group, which are mainly abductors and extensors. This includes the massive gluteus maximus, the gluteus medius, gluteus minimus, and also the tensor fasciae lata slightly more laterally.
Maximus, medius, minimus, TFL.
Okay. Then, deep to the gluteus maximus, you have a group of smaller muscles, the deep lateral rotators. These include muscles like the piriformis, quadratus femoris, the gemelli, superior and inferior, and obturator internus. They primarily rotate the thigh outwards.
Got it. Superficial power movers and deep rotators. Now, thinking back to our first question, the powerhouse for climbing stairs or standing up.
Right. Answer to question 1. The primary muscle doing that powerful hip extension, the one really driving you upstairs or out of a chair, is the gluteus maximus.
Gluteus maximus. Makes sense. It's huge. And it's nerve.
It's innervated by the inferior gluteal nerve, which comes from L5, S1, and S2 nerve roots.
Inferior gluteal nerve for gluteus maximus. Okay. What about medius and minimus?
Those two, gluteus medius and minimus, they're supplied by a different nerve. The superior gluteal nerve, that's L4, L5, S1.
Superior gluteal nerve for medius and minimus. Got it. And you mentioned the piriformis muscle earlier, one of the deep rotators. You said it was a landmark.
Yes, the piriformis is a really important landmark. It runs across the back of the pelvis and exits through the greater sciatic foramen. And it actually divides that foramen into a space above it and a space below it.
Divides the foramen. And why is that significant? Does something important pass above or below it?
Something very important passes below it.
Let me guess. The sciatic nerve.
You got it. Answer to question 2. The sciatic nerve, L4-S3, exits the pelvis through the greater sciatic foramen, specifically passing inferior to or below the piriformis muscle.
Below the piriformis. Okay, so that muscle sits right on top of the biggest nerve in the body. That seems clinically relevant.
Hugely relevant. For instance, if the piriformis muscle becomes tight or spasms, it can potentially compress the sciatic nerve right there, causing pain down the leg, a condition called piriformis syndrome. And thinking about the nerves supplying the gluteals, remember the superior gluteal nerve supplying gluteus medius and minimus.
Yeah, L4, L5, S1.
If that nerve gets damaged, perhaps during surgery or due to injury, those muscles weaken. Now, what do gluteus medius and minimus do? They abduct the hip, but crucially, they stabilize the pelvis when you're standing on one leg.
Stabilize the pelvis, so if they're weak.
Then when you lift the opposite foot off the ground, the pelvis on that unsupported side will drop. It sags down. That visible pelvic drop is called the Trendelenberg sign.
The Trendelenberg sign. A sagging pelvis when lifting the opposite foot. That's a clear indicator of weak hip abductors, likely due to superior gluteal nerve damage.
Exactly. You'll see patients with a characteristic waddling gait if it's affected. It's a classic neurological sign linked directly to this anatomy.
Which brings us right to safety and clinical practice. We know the sciatic nerve runs deep in this region, below the piriformis. We know the superior gluteal nerve is also nearby. This has huge implications for things like injections, doesn't it?
Absolutely. Giving an intramuscular injection in the wrong place here is a serious risk. You could hit the sciatic nerve, causing immense pain and potentially permanent nerve damage like foot drop. You could also hit the superior gluteal nerve.
Okay, so this leads directly to our final question, question 3. To be safe, to avoid that massive sciatic nerve and other important structures, where exactly in the gluteal region should you aim for an intramuscular injection?
Before we give the final answer, let's just quickly tie this all together with how we actually use this limb. Locomotion, walking. The gait cycle is basically one complete stride. It has 2 main phases. There's the stance phase, which is about 60% of the cycle. That's when your foot is on the ground from the moment your heel hits until your toe lifts off, supporting your weight.
Stance phase, foot on the ground, 60%.
And then there's the swing phase, the other 40%. That's when your foot is off the ground, swinging forward to take the next step, from toe off until the next heel strike.
Swing phase, foot in the air, 40%. And all the muscles and nerves we've talked about orchestrate this complex dance.
It's a beautiful symphony of coordinated muscle contractions, nerve signals, and joint movements, all working together seamlessly. Any disruption, like that Trendelenberg sign, affects the whole pattern.
Okay, symphony complete. Now the crucial safety point, that injection site. Answer to question 3, where do we give it?
To be safe, you always administer a deep intramuscular injection into the upper outer quadrant of the buttock.
Upper outer quadrant. Why there?
Because that area is relatively free of major nerves and blood vessels. If you imagine dividing the buttock into 4 quadrants, aiming for the upper outer one directs the needle superiorly and laterally away from the path of the sciatic nerve, which runs more centrally and inferiorly.
Upper outer quadrant. Got it. Literally nerve-saving and pain-saving information.
Absolutely. It's basic, but it's fundamentally important knowledge based directly on understanding the underlying anatomy we've discussed.
So let's wrap this up. We've journeyed from the basic functions and layers through the compartments, the complex nerve wiring via the lumbosacral plexus,
The plumbing system of arteries and veins, the critical muscle pump and valves, lymphatics,
focused on the gluteal powerhouse muscles, saw how nerve damage leads to specific signs like Trendelenberg, and pinpointed that safe injection zone.
and connecting it all, these details aren't just things to memorize for a test. They are the absolute foundation for understanding why patients present the way they do, how to perform procedures safely, and how to diagnose accurately. Structure dictates function, and disruption leads to pathology.
So, thinking about the bigger picture, what's the key takeaway for someone learning this?
I think it's about appreciating the profound interconnectedness, how a problem in one small part, a leaky valve, a compressed nerve, a weak muscle, doesn't just stay there. It ripples through the system. It affects movement, function, a person's ability to interact with their world. So the question to ponder is, how does really seeing this anatomy, understanding these connections, change how you observe, assess, and ultimately care for your patients? That's the heart of clinical reasoning.
That's a powerful thought to end on. Keep exploring, everyone. Keep asking those why questions. Every anatomical detail tells a story. We hope this deep dive has given you a really solid footing for your studies. Until next time, stay curious.